or good afternoon to our friends and colleagues across the country, and welcome to a special USBC webinar. Our webinar topic today is Sustainable Financing Strategies for Community Prevention, specifically opportunities for breastfeeding support under the Affordable Care Act. And welcome, everyone. My name is Megan Renner, and I, along with Amelia Pismite, who you see here, will be your co-moderators today for this webinar. And we're going to start off with just a little bit of logistics of how we will function today on the technology. First of all, to assuage everyone's common question, the recording will be posted on our USBC YouTube channel within 1 business day, so that will be by Monday. This is the link here, which is very easy to remember, just to youtube.com/USbreastfeeding. We also will have links to the slides and I believe a couple of handouts that our speaker will be providing that will also include on that recording posting so that you can find everything there in the same place. During today's session, as with most of our webinars, attendees will be in listen-only mode, but the way to ask questions is pretty simple. You can submit them at any time during the session by typing into the questions box on your webinar control panel. And I'm going to show you a couple of images here of what that might look like. I know sometimes the control panels can get lost and you might only be seeing this little gray bar, and if that's the case, if you click on the orange arrow, that will maximize it and minimize it, pop it in and out so that you can access the more detailed controls. So you can see here on the right side, the questions box is closed down, but if you were to click the little gray arrow next to the word questions, it'll pop out and you'll have a space to type in your questions. So again, you can do that at any time during the session. If you should have any audio problems, other technical questions or glitches, you certainly can chat them to us on the questions box as well. That's another way to send them. But if for some reason your technology is stuck, you can also email to office@usbreastfeeding.org, and we'll be watching that and try to help out as best we can. So before we talk just a bit about why we're here today with this topic, just wanted to mention that this webinar is also happening under the auspices of a particular CDC cooperative agreement funding source that USBC has. It's a 3-year project called the National Innovative Partnership for Addressing Obesity through Environmental Supports for Nutrition and Physical Activity. We are one of 3 grantees, 1 in nutrition, 1 in physical activity, and then USBC in breastfeeding. And so we're very pleased to be able to offer this learning opportunity for our members and partners and coalitions across the breastfeeding field. It is, of course, part of Program Strategy 1 here. You can see around increasing access to professional and peer support. There's also a second program strategy under this funding mechanism around workplace compliance with lactation accommodation laws at the federal and state levels. And you'll be hearing more about our work under that program strategy later on. And we'll also have some webinar opportunities, other sharing and learning opportunities about that in the future. So stay tuned for more there. And now for just a couple of additional words of introduction, I'm going to turn it over to Amelia Pismite, our Deputy Director, who is also serving to steward and manage the work around Program Strategy 1. So Amelia, take it away.
Super, thank you. So as Megan mentioned, we are convening a group that is calling themselves the Lactation Support Providers Constellation. So this constellation is comprised of national organizations that are direct providers of peer and professional breastfeeding support, training, or accreditation programs. We've also gathered together federal government agencies and national public health partner organizations. And at our first 2-day facilitated meeting, the group drafted a declaration of intent to work collaboratively. And in that declaration, they emphasized that all mothers and babies have a right to access to trained lactation support to reach their goals, and that all lactation support providers bring value to the landscape of care. So this is our foundation that we're beginning from. Next slide. So the group also identified 3 priority strategies for their initial collaborative work. The first is to expand training and mentoring opportunities for lactation care providers. And this has a particular emphasis to increase the number of racial and ethnic minority care providers. The second priority strategy is to incorporate breastfeeding support into existing public health programs. And the third is what we're focused on today, looking to advocate for an expanded network of providers allowed to provide lactation care under Medicaid. So today's webinar is the first of several early learning opportunities that we're engaging in as a constellation and that we're sharing with the state coalitions. So this is an opportunity for all of us to learn about the levers for change as USBC, as the LSP Constellation, and as state-level innovators. We know that there are many unique dynamics and needs within every state, while we also recognize the importance and the tremendous value for everyone if we frame a national strategy together. And in a moment, I have the honor of introducing Ann Biasi from Trust for America's Health. And Ann is working with advocates and organizers across many different health topics, such as dentistry, asthma prevention, diabetes maintenance, and community health workers. And we've asked her to come join us in this work because she understands that the inquiry we're involved with on this topic as a field is related to the larger work that's underway across the country to sort through the best ways to provide equal access to care for all mothers through making integrated referral systems between providers so there's seamless continuity for the patient and clarity and consistency around billing practices for providers. And we really recognize that what we're doing in this conversation is difficult, but it's also achievable if we come together in a spirit of collaboration and learning and putting the best interests of mothers and babies before us at all times. So before I formally present Ann, I wanted to also underscore that the goals of the LSP Constellation and today's webinar, this relates to reimbursement through Medicaid. So the conversation today is not relating to private practice insurance plans. So the other thing I want to keep in mind is that neither USBC or the LSP Constellation is that we're convening. We're not here to be dictating policy to the state. So this is really a journey of co-discovery. So as we learn and innovate and share and solve problems together at the national level, we hope to share all of that with you and that as states, you're going to do the same. So this webinar is a first step. And at the end, Megan's going to be sharing with us more about how we can use the new website to engage with one another. So to formally introduce Ann Biasi, Ann is the Director of Policy Development of the Trust for America's Health, which is a nonprofit, nonpartisan organization dedicated to saving lives by protecting the health of every community and working to make disease prevention a national priority. She is responsible for defining the agenda and general strategy associated with the organization's goal to create a modernized, accountable public health system and to integrate prevention into a reforming public care delivery and financing system. So we're very pleased to have Ann with us today, and please lead us on, Ann.
Great. Well, thank you for that wonderful introduction. It's really been a pleasure to work with Megan and Amelia and go along with you on this journey as so many others are on. What I wanted to do today was provide some context for the new opportunities we have to support prevention in Medicaid following upon the passage of the Affordable Care Act, because while we have new opportunities, we do still have work to do, and building the case for that work with busy Medicaid agencies is really important. So I'm going to start out with really the broader picture, which is something that you may be in a position also to be communicating at the state level. And I want to say, I think that that broad picture is very rosy, both because of all the work that you all as a collective have done prior to this, as well as work that other advocates in other fields have done to ensure that while we achieved our first goal with the Affordable Care Act in terms of coverage, we also achieved an equally important goal of looking at prevention as a real opportunity to change our healthcare system in this country. So with that, my overview is really to talk about some of these prevention opportunities, not every single one, but some of the key ones, and with a real focus on how to sustain community-based prevention initiatives. I'll kind of make a distinction between clinical and community-based prevention. I think in this case, both apply, and you are the experts in lactation support, so you can correct me if I'm wrong on that, but it would be my guess that breastfeeding support services are provided both within the walls of clinical institutions as well as outside the walls, either in the home or in community-based settings. So I'm going to cover both, and I'm going to talk about some very specific opportunities within Medicaid. Informally, I like to call these new flexibilities. I'm not sure if Medicaid would like to be called flexible, so in this case, the written word you see is opportunity. So I'm going to talk specifically about a rule change in the preventive services component of Medicaid, as well as waiver authorities, and some opportunities to work directly with the payers locally at the state level in managed care, states with managed care. So first about us, Trust for America's Health. We're a nonprofit, nonpartisan organization. We're all about prevention and public health. We're not a membership organization. We're a small evidence-based policy and advocacy shop. Inside the Beltway, I think we're best known for our government relations work to really promote increased federal investment in prevention and public health. And outside of the Beltway, hopefully you know us by our reports that can get a lot of attention to different issues, including some that folks might not have thought of as public health issues previously. So an example of that is in the last couple of years we did a report on prescription drug abuse, which of course now is broadly considered to be a public health issue, but just a couple of years ago wasn't, even though the number of deaths from prescription drug overdoses started to override the number of deaths, for example, from automobile accidents. So that's kind of what we are. We're real small. We're foundation funded. We don't take any corporate or government funding. Part of what we do is serve as a watchdog on the government, and because we don't have any membership, we can be fairly flexible and unbiased because we're not selling any particular agenda, just what's best for the American people. First, kind of to take the big picture, like I said, in the Affordable Care Act, we had this great opportunity that a community really rallied behind with TFAH's leadership to get significant new investments in prevention and public health. And I'm going to show you a little bit about the Prevention and Public Health Fund, which was really a key component of that. And I'm also going to talk about the National Prevention Strategy because it provides such a good case for breastfeeding at such an important level. And having said all that, you know, we've got all these great things. We still have a lot of challenges. I mean, even on the coverage side, what a challenge it has been to get an additional 10 million Americans enrolled. We have the same challenges ahead of us in terms of implementing those great provisions of the Affordable Care Act to really shift our system to one that focuses on prevention. I just want to check in here with make sure everybody can see my slides, or if there's a problem, hopefully somebody will let me know. Okay, so what changed and why did it change? Well, like I said, through the Affordable Care Act, we gained not only a National Prevention Council, but also, importantly, a National Prevention Strategy. At the same time, you know, we are moving towards universal coverage, including first dollar coverage of clinical preventive services, very important for this call. And we've created this funding stream through the Prevention and Public Health Fund to really support core public health functions, clinical and community prevention, the public health workforce, and public health and prevention research. But the key point on this slide is, how did we do that? Well, public health came together like never before. You know, oftentimes in sectors of our society that are, you know, losing some of their dollars because funding for public health has been decreasing over the years, folks tend to go back into retreat into their corners and protect their piece of the pie. But in this case, and there were, not to say that there wasn't controversy in seeking to get a dedicated funding stream for public health, there certainly was. Nevertheless, the community was really able to align and speak with a unified voice and reach out to others who cared about these issues but might not have been traditionally engaged, the business community, the faith community, even to a certain extent the healthcare system itself. And so I really wanted to emphasize that to build on what Megan and Amelia said. I think in doing this implementation work, this collaboration and this unification of the voice is really critical because there's so much happening in implementation. Policymakers and decision makers are going to stay clear of anything that seems fraught with conflict. So they're going to try to move ahead on those things where they see a unified community that will applaud them for doing the right thing. So what are some of these key prevention measures? Well, if I haven't mentioned the National Prevention Strategy enough times, let me just mention it one more time because it really does create this broad definition of what creates health. And it talks about cross-cutting initiatives between federal agencies, and we've really never had that before. The Prevention and Public Health Fund invests in community-based prevention programs. We have a new opportunity to leverage the more rigorous hospital community benefit requirements that nonprofit hospitals have to adhere to. And we have these new Medicaid opportunities, like the Preventive Services Rule change that we're going to focus on today. These levers in our world are really key. So the National Prevention Strategy. We've got 4 pillars here, and I really want to focus on the one in the upper right-hand corner of the diagram, which is clinical and community preventive services. Now more than ever, people understand the need to connect what is happening in the clinical setting to what is happening in the community setting. Or otherwise, we're never going to achieve our goal of keeping people healthy and getting people healthy who are already sick. And that's really been a new focus, and I think it's something, a really good framing when we think about access to support for breastfeeding. Now, specifically within the National Prevention Strategy, we've got a lot of references to breastfeeding, and that is so great. It talks about supporting policies and programs that promote breastfeeding. It calls for specific actions by various sectors of our society, and it includes a target. So what are some of those recommendations? Hopefully all of you are aware of these, but of course that babies be exclusively breastfed for the first 6 months. And then important to this conversation that community, nonprofit, faith-based organizations implement appropriate social supports for breastfeeding. These are your partners. These are the organizations that are being called on to work with you in this journey. Businesses, employers, another part of society that's being called to work with you in terms of adopting lactation policies that provide the space and time for breastfeeding, particularly for people who are in low-wage jobs who might not have access to those services. And then I highlighted this in red because this is really key around partnership. State, tribal, local, and territorial governments should work with hospitals, early learning centers, healthcare providers, and community-based organizations to implement breastfeeding policies and programs. As state-level coalitions, this is you. You fit right within this, that this is a call to you to work with your partners at the state and local levels to implement these programs. So a little bit about what did the Prevention and Public Health Fund do for breastfeeding? Well, there's actually a line item in there. Now in this case, it's supporting baby-friendly hospitals and breastfeeding. It's continued to increase in the President's request. We're still at $8 million. It's a good amount of money. It can continue to grow through your advocacy. And in fact, some of this money has supported USBC in its efforts. Separate from the Prevention and Public Health Fund, in the discretionary budget, we also have support for breastfeeding. And going back to the very first ever investments in prevention at the community level, those were Community Prevention to Work grants that were a part of the stimulus bill. There's always been a focus on breastfeeding. So when we're talking about community health improvement work generally, please remember that I think everybody in the prevention community considers lactation support and breastfeeding to be a part of that work. And that's evidenced by the fact that grantees under these even early programs. And I'm pointing to some specific states on this slide, like Arizona, Florida, you know, in the community transformation grants, which were the next iteration, really, of community prevention coalition work at the local level. Additional states focused on breastfeeding within their grants. And now, with the newly launched Partnerships to Improve Community Health, we even have a very specific focus, which I think is really exciting. So by additional investments on this slide, what I mean is above and beyond the Prevention and Public Health Fund itself, we have additional investments through these Partnerships to Improve Community Health. There are national implementation and dissemination partners. They're meant to really support the grantees, and their funds are used to build community capacity or to provide technical assistance. In the case of breastfeeding, the National WIC Association has a reward of over $2 million to build community capacity by subgranting dollars locally to add on to the coalitions that have been developed through these Partnerships to Improve Community Health grantees. So specifically, that money will support 36 local WIC agencies to either create or enhance one of these general community health coalitions by including the WIC agency, an OBGYN, and a WIC mother or patient supporter in the coalition leadership team. It will also support the performance of a community health needs assessment and the development and implementation of evidence and practice-based strategies addressing the lack of access to chronic disease prevention, risk reduction, management opportunities, and poor nutrition. So our first question to you all listening on the line today, I'm going to turn it over to my colleagues who will give you a poll question here. And do I need to turn the screen over, guys? Okay, there you go.
Oops, I'm sorry, folks. Can you hear me now?
Oh, now I can.
Oh, fabulous. I'm talking to myself because I'm muted in another place. All right, so you guys saw we had, were you able to see the response? We had about 27% said yes and 73% said no to the. We also had a few questions about what you meant by connected and, so I don't know if you want to say just a bit more about what sort of connections you mean before we move on.
Sure, yeah, that's a great question. So I guess what I was thinking is because, you know, there has always been an emphasis in these community health improvement programs on breastfeeding as one important prevention opportunity, and now there's a very specific focus through this community capacity building that WIC will be doing by subgranting. I was thinking it's an opportunity for all of you as state-level coalitions to kind of get in on that game. also to be connected to broader community health improvement efforts that are supportive of what you're doing, where you can work in concert with others. So I'll talk more about that when we get into talking about how you move forward on implementing or taking advantage of these rule changes to support your work in your state. But partnership with others in the prevention community can be a really important strategy. So I was thinking to get to the table of these local coalitions could be a good thing for you to be doing now.
Awesome. So it says that we're waiting to view your screen again, so I think you might have to click play again on your slides.
Okay. Is that working?
Yep, there you go.
Great. Okay. So no, okay, there we go. So as I was just saying, I think it's important to get to these tables where community prevention is being funded and where things are moving in your community, because what we think about here at TFAH in terms of moving this work forward and getting even more investment is that the future is really going to be determined by the success of our current efforts and letting everyone know about those successes. And we emphasize that a lot about the need to tell our stories to policymakers. And there's really important reasons why we need to do that, because when we don't, they are not aware, and then they don't work to protect those things when there's budget fights on Capitol Hill, like we just went through. Just in fact, Tuesday of this week, there was a vote to repeal the entire Prevention and Public Health Fund, and we were able to beat that back by about 7 votes, I believe, in the Senate. It was very close. So it's really important that legislators understand the success of your current efforts, what you're currently doing in the community. And I think you can help to broadcast those successes by being part of these broader coalitions that are working to do that type of communication. Also, it's really important to document the return on investment. There's no question that we're looking to lower our healthcare costs. Someone told me today that people that are dually eligible for Medicare and Medicaid, which is not that many people actually in the country, those people, which is less than 11 million nationally, consume fully 2% of our gross domestic product. I mean, there are just some parts of the population that are utilizing healthcare services at a much higher rate than others. So there's a lot of focus on how to reduce that. We know that in this field with babies that are born prematurely. They utilize a lot of resources, and rightly so. We need to work to get those kids to be as healthy as they can be. At the same time, if we can invest in things that we know work in terms of prevention, and we can show the return on that, policymakers will be very receptive. Similarly, it's these partnerships, both within the clinical system with our clinical partners, but also outside the clinical system. I think that's why the language earlier on working with early learning centers and others who care that kids are ready to learn and as healthy as they can be is so important. And then, of course, the future is going to be heavily determined by the resources we have available to us. So that's why at TFAH we like to work with communities to try to leverage these new funding streams, leverage new opportunities for insurance reimbursement, and particularly in Medicaid. So just a little making the case here. And I think you have the opportunity to do this on breastfeeding, which is my third point on this slide. You have great data, both in the literature and I'm sure through a local data collection as well. At TFAH back in 2008, a long time ago now, we did a study to make a case that an investment in prevention would have this amazing yield. And that has gone so far to really convincing policymakers that it was as important as insurance coverage is. So I encourage you to be working on making that case, using the national level data, but augmenting that with your local data. So let's start with, I think, what's kind of clearer and easier for all of us to understand, which is straight coverage. So as you all know better than me, through your advocacy, the U.S. Preventive Services Task Force gave recommendations around breastfeeding that allow breastfeeding to be covered as a type A and B service. What does that mean? That means that both between the U.S. Preventive Services Task Force recommendation and the HRSA's recommendation under Women's Services, again, which I'm sure you all know well, what does that mean? Why is that so important? Well, that now means that private plans have to cover these services with no cost sharing for the patient. That doesn't mean that they are. It means that they should. We're going to talk about in Medicaid how the expansion plans must cover them with no cost sharing for the patient, and Medicaid traditional plans can choose to, and they have a carrot, which is a pretty big carrot, which is a 1% boost in the federal payment for those services. Now, the tricky part comes in implementation, and I wish it was easier, but we all go through this. The U.S. Preventive Services Task Force or HRSA or some other federal authority gives some guidance and says such and such should be covered. Then we have to figure out how to translate that federal guideline into insurance coverage. So on this slide, I reference what I think is a sentinel document in this field, which is the Centers for Medicaid and Medicare Services 2012 issue brief around lactation services, which says CMS encourages states to include lactation services as separately reimbursed pregnancy-related services. So that's the first thing we should all be really comfortable with, that the federal government, both from a perspective of what works in healthcare and from a perspective of what should be covered and paid for, they're fully on board. They totally believe that lactation services should be covered. So the tricky part then is just how that gets done, both the process and the technical details. So there's a couple of ways you can move forward at the state level. You can work with your state Medicaid agency to either implement new benefits in fee-for-service or to encourage and require coverage of new benefits in managed care. And I'm going to go into each of these. There's also additional opportunities, I think, to leverage new flexibilities and to really go for that carrot of that 1% that I just mentioned. So let's get specifically into Medicaid now. Okay, Medicaid has a lot of, as they call them, tools in their toolbox. These are recently created tools, some of which you may be aware of and maybe others you don't know about. So let me give a couple of examples just to get us started, and then we'll talk about it specific to lactation services. So CMS has really been responsive to what we as advocates have told them, that they need to be more flexible in how they pay for things, in the type of providers, the type of services that are delivered, and the settings in which those services are delivered. As an example, in Medicaid, they approved a waiver. This is for kids who have asthma, and what it would allow is a bundled payment for pediatric asthma cases that qualify, and that bundled payment would include payment for environmental assessments that are conducted by community health workers in the home and even sometimes in the school or daycare setting to find out what are the environmental triggers that a child is exposed to that's exacerbating their asthma, causing them to come to the emergency room and need additional treatment in the school. So Medicaid doesn't usually pay for things that occur in the home. They don't usually pay for environmental assessments. So that's what they're waiving here. They're waiving their traditional requirements, and they're being more flexible and being willing to pay for some different things. And in this case, it's a pilot. They'll see how it works and then see if they can expand it. Another example, one that's gaining foothold across the nation, is the diabetes prevention program. So in this case, Medicaid, in most instances, and there are exceptions, doesn't pay for a diagnosis unless a diagnosis has been given. And in this case, the whole idea is to prevent a person from becoming diabetic. So they identify people who are pre-diabetic. They provide services of a lifestyle coach in a group setting in a community-based organization such as the YMCA. So again, Medicaid's being flexible in what the services are, lifestyle coaching in a group setting. Who's providing that service? The lifestyle coach. Where is it based? Not in a primary care provider's office or in the hospital, sometimes, but also can be in a community setting. So they're waiving what were very restrictive requirements for how things got done. And we want to talk today about a specific opportunity that will allow payment for, quote, non-licensed providers, providers who aren't otherwise licensed by a state. And this is relevant to preventive services, and that's how the rule changed. There's a kind of a backstory to this, which is that CMS really found that there was kind of a discrepancy between the federal statute and the regulation, and thus that their regulation was too restrictive in saying that preventive services could only be provided by licensed providers. And they realized that was restrictive, and it didn't capitalize on the evidence as we know it today. So they, in their words, aligned the federal statute and the regulation, so it now allows for states to pay non-licensed providers who provide preventive services. I want to give some breastfeeding examples before you think I'm not going to talk about that at all. So according to a survey that I know is being developed but not yet public, about 17 states cover lactation counseling services in Medicaid. And I look forward to our Q&A time and discussion to hear what your reaction to that is, if it sounds about right to you or not. Now, they differ in how they do that. And in Medicaid language, what that's called is amount, scope, and duration of coverage. So the states differ in exactly how they pay for something and what they pay for and who they'll pay to provide it. And that, again, in the Medicaid language is called amount, scope, and duration of coverage. And that's typical. Medicaid is a federal state program. So the feds don't like to dictate to the states how they do things. So rather, they like to make these generalizations. As I mentioned earlier, that the states should provide lactation counseling as a separate pregnancy-related benefit. I hope I got that about right. They say that general statement, and then they leave it up to the states to decide exactly who, how, where, how much, all of those details. And that can be a challenge because that means then that we need to, get each state to make some changes. However, I think what we found, and advocates have found throughout the years, is if we work together at a national level and try to come as an industry, come to consensus around what we think that benefit should look like, it's really helpful for states because states don't like to reinvent the wheel. They don't have time to reinvent the wheel. They don't necessarily have that expertise. So if as a profession, the U.S. Breastfeeding Committee and through the Lactation Support Providers Constellation, and what I hear in your declaration of intent is an opportunity to work together to come to some consensus on what a Medicaid benefit for lactation would look like. And then that would really help the states move forward in actually implementing it. Because as I mentioned earlier in the call, policymakers stay away from things that are fraught with conflict. But when they see a profession all on board together advocating in a unified voice, as the public health did during healthcare reform and gained millions and millions of dollars to be poured into prevention and public health, that's really when policymakers will act, including state-level policymakers. And I'm sure you all have your own stories of that. So here's a couple of early examples. It comes from that CMS issue brief that they put out in 2012. They provided these examples in talking to their state Medicaid programs. They talked about the fact that New Hampshire covers the maternal postpartum assessment, including evaluation of how the breastfeeding is going with the mother, and postpartum education to ensure that the breastfeeding continues if there's issues. Florida classifies high-risk patients or takes referrals from their providers and coordinates prenatal care monthly through outreach and case management, again, working to make sure the mother has whatever services she needs for the best outcomes. So that's just a couple of examples that CMS highlighted. What are the opportunities to create more of those examples? We want to specifically focus in today on this opportunity for Medicaid to pay non-licensed providers because so many lactation consultants and others in your field that provide lactation counseling and support might not be licensed by their states. And there's definitely benefits to that. I could see why a profession would not want to be licensed with all the costs and headaches and regulation that comes into play and restrictions that licensure can bring. At the same time, I think states and federal policymakers have realized that there's an opportunity for well-qualified and trained providers to provide very high-quality services that will have a positive impact on the patient population. And thus this rule change I referenced earlier, which allows reimbursement for providers outside of the licensure system, as they call them in the rule change, otherwise qualified providers. I really like that because it's got the word qualified in there. So until recently, that wasn't allowed. In terms of preventive services, states could only reimburse services provided by a physician or other licensed practitioner. So this new rule change means that states can now choose to pay for preventive services provided by practitioners who fall outside the state licensure system, provided that the service was recommended by the patient's physician or other licensed provider. So that's our opportunity that we really want to zero in on. And what we've been saying at TFAH is that this can apply to a number of different types of workers. And be happy to hear more. This is just a list that was put together at a meeting of federal, state, and local policymakers and programmatic folks. We convened back in October 2013 to really get into this rule change and figure out how is it an opportunity for prevention. So there's some important, very important things to remember. First of all, this rule change applies only to preventive services. Now, there are other opportunities that apply to other types of services, such as inpatient services, outpatient services, laboratory services, et cetera, et cetera. But this rule change in particular is restricted to preventive services. It is upon referral, so a licensed provider, as I just referenced, must make the referral. It only applies to fee-for-service Medicaid, and we're going to talk more about that. In order to do this, a state must submit a state plan amendment to the federal agency, the Centers for Medicare and Medicaid Services, or CMS. That's a little bit of a process. In some states, it might require legislation, but it is something that states are used to doing when they want to tweak their Medicaid program for the good of the beneficiaries and the good of the state. An important point to note that because I think a lot of the patients that you would want to be able to have access to this new benefit are in managed care already, right? Because more than 50% of moms and kids are in managed care nationwide. I can give you a resource if you'd like to be able to look in terms of your own state and see our target population, are they in managed care or are they in fee-for-service? If they're in managed care, who are the managed care organizations that are providing that care? There is a new resource on the Kaiser Family Foundation's website that allows you to actually find out who are the managed care organizations that are serving the Medicaid population in your state and how much of your state Medicaid population is enrolled in managed care. So those resources are really helpful for you at the state level. I'm happy to provide those links. So I'm going to turn now more to implementation. What are the steps? What's necessary to pursue this opportunity? So I think the first thing to always do is kind of know how it works now, and you probably all do, and maybe it doesn't work at all, maybe there's no coverage, but to kind of find that out so that we work from where we are and improve upon that. And then really define what you want to change. And as I referenced earlier, I think this is an opportunity to work together at the national level to do this because, you know, it's just so much easier for states. They really, you know, they like their independence. Yeah, we understand that. But they also, at the pace that they're working to implement their exchanges and their Medicaid expansions, with all the changes in healthcare, we found it's really helpful to make it easy for states. They like to also see what their neighbor state is doing. So again, having some kind of a national recommendation could really go a long way to getting states to move more quickly. It's important to gather all the supporting information to really make the case, and we're providing a handout to you that includes a questionnaire that really is a template for gathering the information that would be needed to approach your Medicaid agency so that you had everything in hand in terms of what they might need or ask for. And then there you go. You can go meet with your state Medicaid agency. And oftentimes, if there's a medical director, that can be a good way to go. For your services, you might also want to work through your state maternal and child health office and public health and see if they have a relationship with the Medicaid office that you could leverage to have this conversation. And equally important, I think, you need to be meeting with your Medicaid managed care organizations. And when I say that, a lot of folks ask me, well, how do you do that? Who do you even ask for? Well, once again, the medical director is often a good person to approach because they know the evidence base. They know the U.S. Preventive Services Task Force recommendations normally, or if you were to point those out to them, they would totally understand how important they are and what they mean in terms of policy. So the medical director is a good place to start in the Medicaid managed care organizations, or you may have your own relationships with various programs. And I can tell you, I sit on a best practices committee for the Medicaid Health Plans of America, and in looking through the nominations for the past 2 years of the best practices from all the Medicaid plans, a lot of them were approaching these issues, at least working with their new moms. If it wasn't lactation services, through outreach and education and other ways. So I do think you have a receptive audience at the Medicaid Managed Care Organizations, or MCOs as they're called. So when you get there, what do you need to do? Explain the health issue you're addressing. Now that might take you a while in terms of talking about breastfeeding since it addresses so many health issues. Describing the actual intervention. This would be the who, what, where, when, kind of who's doing the intervention, what exactly is the intervention, i.e. is it a 15-minute face-to-face, a 30-minute face-to-face, a 45-minute group setting, or something else. Maybe you want to be able to offer supplies within that, like a breast pump. So really describing what the intervention would be, the level of evidence of effectiveness. And again, you've got that all sewn up with the HRSA and the U.S. Preventive Services Task Force recommendations, so that's an easy one for you. Moving on, I think this is where it gets sticky, and this is what I've seen as I've worked with other professions, be it in the dental world, generally in health education, really, mental health and substance abuse providers, anybody who might be looking at this rule change, is talking about what providers you propose and what services they'll provide. So this is where we get into scope of practice issues. Now, if you were licensed, your scope of practice issues would be determined by licensure. But in this case, since by definition of using this rule change as an opportunity, it's a non-licensed provider, there's not something that you can just look to and say, well, this provider does that, and, like a nurse practitioner can do this, but a doctor can do that, but the medical assistant can do that, and the nurse can do that. All those things are just decided by licensure. In this case, perhaps there's an opportunity to come together again under the Lactation Support Providers Constellation to really kind of chart it out. So these are the support services that women need to initiate and continue breastfeeding. And these are the type of providers who are qualified by their education and training to provide those services. That's going to be really important. And why is that? Well, think about some of the things you read in the paper, some of the scandals that occur, for example, in home health agencies, or, Medicaid directors, they worry about quality. They worry about fraud. They don't want anything to end up in the newspaper. They like to be handed something that says, these providers have these skill sets based on this education and training. And oftentimes they might look to their public health director for a nod as if that's correct. So I think that's really where an opportunity was. And I could see a chart that would have, in the first column, I don't know, what go one either way or the other. One, either the columns are services and the rows are providers, but one way or the other, and check marks to show, in a graduated schedule. A peer support provider can do this. And then, you know, maybe, I don't know, all the professions, I'm sorry, in lactation because I'm not familiar, but a CLC can do this, or an IBCLC can do this, this, and this. So really, it becomes almost like a graduated schedule. Some providers who have less education and training clearly will have to do the clinical services on one end of the scale. And then other providers who have more education and training can do more complex services. And what that's being called nowadays in this whole area is being called operating at the top of your license. Now again, in this case, the license doesn't apply, but the concept holds true, is that in order for us to have an efficient healthcare system that provides the best care at the lowest cost, everyone needs to be operating at the top of their license. It doesn't make sense for a physician to be doing outreach that could be done by a community health worker, for example. Or I'll use dental. I worked in that field for a while. It really doesn't make sense, to tell you the truth, for a dentist to be applying sealants, because that can be done by a dental nurse therapist or a hygienist. But when it comes to pulling a tooth, you probably want the dentist to do that. So it's natural. It happens in every profession that there's differences in the types of providers and the services they provide. And that is a really important part of this rule change. Similarly, which Medicaid beneficiaries would be eligible for the service? Well, this is, in this case, postpartum women, right? This is not available to certain segments of the population. So that's what the third bullet is referring to. And actually, just to go back up there for a moment, the state is even going to want to know for how long. So how long postpartum? And that's, of course, going to be based on the evidence. So a part of all this defining the scope is really looking at the educational background, the training, the experience, what type of credentialing, registering, or any other system that exists out there for the profession and that particular provider in the profession, and then what the employment model is. And what I mean by that is really how is it that they're operating independently, like nurse midwives might be hanging out their own shingle? Are they employed by, say, a federally qualified community health center, like many community health workers are? What's the employment model? As I mentioned earlier, with the diabetes prevention program, using that as an example, in some cases, those life coaches are employed by the local YMCA. But at the same time, they might be embedded in a primary care practice. So there's all kinds of different employment models. Now, I mentioned before, most of this, kind of how you explain the intervention that you're proposing. What are the services? What's the evidence of their effectiveness? How will that referral process work, since it might be something new? How will the licensed provider know that there's an opportunity to refer to a certain type of lactation provider? What's the unit of service? Then, like I said earlier, 15 minutes, 30 minutes. Some are time-based, some are procedurally based. What are any limitations on the service, such as only 2 or 3 visits? What location limits or requirements might they be? Hopefully, you'll be able to advocate for pretty broad location opportunities. And then what should the reimbursement level be? And of course, the state's going to decide this themselves, but certainly you can provide data around, for example, average regional salaries for the different providers, or the cost of supplies or supports, maybe breast pumps is an example there. So as you're doing all of this, what's important? You got to partner and you got to persevere. It's not going to be easy. We've been working on this, again, since late 2013, and we have yet to see any state submit a state plan amendment to cover any type of non-licensed provider, despite lots of activity happening. So I just want you to know it's not a short road in front of you. Medicaid agencies have a lot going on. I think the shorter road, personally, is to work with your managed care organizations, because they have a lot more flexibility. They don't have to submit a state plan amendment. They can just go ahead and do it. And as I mentioned, I mean, from my scan of that industry, and I'd like to hear your opinion as we come up now to the Q&A section, that, you know, I think that they're willing, if they know what the evidence is, if they can see that services might be delivered at the same quality but a lower cost, they're certainly open to those kind of proposals. So I really think there's an opportunity. I think there's a third opportunity, which is very difficult, but if accomplished, can have a great impact. And that's the opportunity to work with the state Medicaid agency to require managed care organizations to cover certain services provided by certain providers. So an example of that is in New Mexico, where they encouraged the managed care organizations, or yeah, I think it was encouraged in New Mexico, to cover community health worker services. And they offered an additional payment as a part of their per member per month capitation rate to actually cover those services. So there was a nice carrot for the managed care organizations, and in fact, they're mostly doing it. In South Carolina, they required the managed care organizations to cover community health worker services. And the typical time that that happens is when they're putting out the request for proposals to the managed care organizations. So that's something that you can talk with your state about, as whether there be an opportunity to do that. And quite honestly, I think those are both important opportunities. The one, working with the managed care organizations, because I think that can be the quickest route, and the working with the state Medicaid agency to mandate the managed care organizations, because that can be the most comprehensive route. But that doesn't mean that you can't work on the fee-for-service route if you look at your state data and you see, in fact, that some of the moms that you're trying to cover are actually in the fee-for-service market. But make sure that they're there first, because I think for moms and kids, they're mostly in managed care. So I can't emphasize the need to partner and collaborate enough. I think if I were a state Medicaid director, my worst nightmare right now would be to be getting requests from every non-licensed provider out there to submit a state plan amendment. So I'd have the community health workers in my left ear and lactation consultants in my right ear, and the health educators right behind them, and the family life educators, and the parenting educators. And there are so many people who contribute in great ways, and they all have a great case to make. I personally think you have a very, very good case in lactation, but I still think if others are moving forward, and I know of many, many instances where the community health workers are really gaining steam, it might be well served for you to work with them rather than, you know, everybody kind of knocking at Medicaid's door separately. And then I don't want you to forget, of course, your public health partners. You know, they're there for you, and they have a lot of data that can help you to measure the outcomes. And they might have a relationship with their state Medicaid agency. I know traditionally that really hasn't been the case, but that's happening much more now. So I think you have an opportunity to work with your public health agency as a partner. We want to ask our second and third polling question today, because as I'm recommending these strategies to you, I'm curious how many of you out there might already be doing it. So we'll turn to the second Medicaid polling question, which is asking you, and I don't know why, maybe I need to turn off my screen so others can see the poll.
I just launched it, Ann. So
okay, you launched it. I guess I don't know. I don't see it on here. I don't know why. But you're asking the question about whether you're working with your state Medicaid agency?
Yes, ma'am.
Okay.
And I guess we should have added an I don't know, but how about for the purposes of this polling, if you don't know whether you're, you know, anyone with your coalition or your organization is working, just don't respond to the poll, and I'll include that percentage as the I don't know. So, all right, I'm going to give it a little bit more time. It looks like we're slowing down here. Okay. All right, so I'm going to close this one down and share the results. So we had a similar response to the last one, about 1/3, 2/3 roughly, 30% saying yes and 70% saying no. But there was a good number of folks that did not respond, so we'll assume those are I don't knows or not sure. So,
well, that is great to hear. That's awesome. Yeah, 30% is great.
Yeah. Do you want me to launch the second one now, or?
Yeah. doing the second strategy in terms of working with the managed care organizations, which sometimes feels more daunting, but like I said, I think can be easier. And I need to be corrected if I'm wrong on that, folks.
Yeah, okay, so you should now be seeing the third poll question. Are you talking with a Medicaid managed care plan about reimbursement for lactation services or supplies? And that's a newer strategy to us at USBC, so it'll be interesting to see how the response flows to this one. And again, if you aren't sure, just don't respond. Unfortunately, when it shows you the results, it's going to do the percentage based on the responses, but I can tell you the approximate numbers of who did not respond. We'll give it just a few more seconds. Looks like we've slowed down. Yeah, similar. So about 40% of the attendees did not respond. So I think that probably means they are no's. I'll close this one down, and we're similar again, 31% yes and 69% no. So similar, but a little bit higher than the other one.
Well, that's awesome. Again, I think that's great, and I think, you know, these type of things do tend to go in a third, a third, a third, so that seems to make sense.
Yeah.
But I think that there's a real opportunity to learn from those early experiences. And obviously, at the same time, you have your joint work going on in terms of your declaration of intent to work together in this constellation. So it seems like the train is moving forward. So I actually ended my slides. I just have a contact slide. Let's see. There we go. There we go. So that's how to reach me. And I'd be happy to
we lost it, Ann. Did you maybe hit the play button again?
There you go. Sorry.
There you go.
I pushed it off and said on. There you go. So there's my contact information, our website. There's a couple of handouts that support kind of like a primer on the rule change, and then the questionnaire that I mentioned that you could use to gather the information to prepare yourself for these conversations. That was developed by our partner, Nemours. And then there's a Q&A because what I have heard from the field, and particularly from state Medicaid directors, is they would like more guidance from CMS in really leveraging this rule. And CMS doesn't intend to issue any more guidance. As I said, they don't like to tell states what to do. They prefer that states approach them and say, hey, we'd really like to cover lactation services. Here, what are the options to do so in our state? And so the Q&A was developed based upon all the webinars and other presentations that we've sat on when we've heard CMS talking about this rule change. So we kind of tried to extract as much detail from those presentations as we could. And those the presentations themselves are referenced in the Q&A.
Wonderful. Thank you so much, Ann. In the chat box while you've been speaking, we've had a number of people commenting on how timely this is and what a great presenter you are and how you're making this really complex body of information accessible and, you know, really being inspiring to people. So thank you so much.
We do have you.
Yeah, we're really happy to be working with you and learning from you. So some of the questions that have come through are related to people looking for some resources that you mentioned. And so Megan is in the process right now of posting links for folks. And she's also going to put those links up with the recording. So you're going to have a lot of the references to the different materials that Ann talked about will all be available for you and easily accessible. But one of the questions that we had from early on, Ann, was when you were talking about the different CDC funding streams, do you have a suggestion about where people can go to see information about you know, who is receiving that funding within communities?
Oh, I'm so glad that question was asked. Yes, I do. I can definitely get a link for it. You know, that's been a frustration of ours with the CDC is they tend not to post this stuff publicly or with any name, you know, or any way that you could really contact someone. but I'm pretty sure that all the pitch grants are published along with the principal investigator. So I can get you a link to that. And the other thing, coming soon, not quite available yet, although let me explain what it is. We have developed what we call a dashboard of public and private funding opportunities for community prevention, which includes the CDC grants, but it also includes another 40-plus public and private funding sources for community prevention. And we would welcome hearing any sources that we haven't included so we could augment it and add those in. And what we're doing now is developing that into a queryable online database so that all of you could go in and find out in your state who's funded to do whatever you want to look for, obesity, tobacco cessation, you know, people that in health that are doing housing work, you know, whatever. And we certainly, to the extent that we have, you know, anything that would support lactation or breastfeeding, we can appropriately tag those grants to that so that that can be a search term. So we might need your help just in identifying the sources of grant funding. And then that database is going to be linked to a database of models and success stories that TFAH's been developing for some time on our website, and that we were able to augment through a conference that we helped the Robert Wood Johnson Foundation convene last year. So you might go and search, I'm looking in Alabama, and I want to see who's funded to do obesity work. They might be interested in promoting breastfeeding. And you could, at the same time when you were looking at that, up would pop stories about how people are addressing obesity and using breastfeeding as an intervention. So it's going to be really exciting that you'll be able to look both at funding sources and at various models, and then we'll have links to the evidence base, the various sources including the task force, the community guide. We have a compendium that we produced through contract with the New York Academy of Medicine. So of course you want, you know, everybody wants to look at what the evidence-based practices are. But I think we're also interested in what the innovation is out there in the field. And that's the purpose of really having these models. And then everybody's interested in funding, I know. So that will be a great place for you guys to go in the future. I have to say it's not online now. We're currently working with a developer to get it up online. Right now it is a massive Excel spreadsheet. And if anybody would want to try their attempt to access it, they can. I found it really easy. I was just able to go, you know, into the state column and then look for the grants I want. But, you know, I'm pretty comfortable with Excel. So I think anybody that is probably would be able to use this database in its current form, and then pretty soon you'll have the fancy version online. But in the meantime, if you want to know specific to these CDC grants, I'm sure that I can find the link to send you as to where they're posted on the CDC website.
Wonderful, thank you. And I swear that was not a plant, but it was you're the perfect person to ask, and we're really glad that TFAH is tracking all of that and making it even more accessible. So we have a few specific questions. There's a question, when you were talking about the 1% increase for payments for plans, you know, that, yeah, the traditional Medicaid, there's a question, is that for all payments or is that only for lactation? Like how big is this carrot?
Yeah, that's a good question. And I think that's a policy issue right now, because I think that there was an assumption that it would be for all services, and I think what's happened is it's been only for those, you know, the primary care interventions that, you know, were added. So in other words, much smaller pot of money in the way that it's been implemented. So I think that's actually a policy question that the advocacy community is kind of working with CMS on right now. You know, what was the congressional intent and what was the implementation? So that's a really excellent question. It's at least a little bit, but it might be even more. I can tell you what it says. I have in front of me the CMS memo, and it says, because primary care interventions to promote and support breastfeeding received a grade of B from the U.S. Preventive Services Task Force, coverage of lactation services without cost sharing will be eligible for a 1% point increase in federal medical assistance percentage, the FMAP, and per whatever section of the Affordable Care Act. CMS encourages states to begin formulating coverage policies for such services, which is just such great fodder for you to take to your state. So I think from that, you know, it would tell me that their interpretation is it is just for the additional services.
Okay, thank you. So we had a question asking if you see implications for prenatal lactation education.
Ooh, well, I guess it depends on, you know, what the evidence shows. So I don't know if, you know, was prenatal rated by the task force, or did the task force even address when the education would occur?
I'm not sure. I think not. Megan, are you sure? Do we need to look at that?
I'm not recalling what the task force recommendation says at this moment, but I believe that don't the HRSA guidelines talk about both prenatal and postpartum, that the lactation education could occur? Because it is based on both of those sources, correct, Anne?
Yes, yes. So you're absolutely right, and I would also think, you know, if those two don't cover it, just going to AAP and seeing what their policy, that would be really helpful, you know, at the state level in terms of taking the AAP's policy on that, which I'm assuming would include prenatal education.
Mm-hmm. Yeah, the HRSA Women's Preventive Services Guidelines mention comprehensive lactation support and counseling by a trained provider during pregnancy and or in the postpartum period. So for certain that one, I'll have to look up and reread the Preventive Services Task Force language again.
Perfect.
If I find it before the webinar ends, I will post in the chat.
Yeah, even the HRSA I think is plenty. You know, that's great.
Mm-hmm. Super. So then we had a question if you have other current examples that exist for payment of non-licensed providers. I know you spoke a little bit about some emergence, particularly around community health workers. Do you have anything else that you can share about that? And also what the level of payment is?
Well, I don't know that I can get down to that level of detail just because at TFAH we're pretty small, so we don't really do technical assistance at the state level. So I don't usually get into that level of detail of the amount. But in terms of how this worked, even before the preventive services rule change was even known, Minnesota had moved ahead with 3 providers. So let's see, make sure I get them right. Community health workers, community paramedics, and dental therapists. So they reimbursed those 3 providers. They decided to do that themselves. They must have done it through a waiver authority, I imagine. And now I can provide numerous examples of Medicaid managed care organizations that are either employing, paying for, or paying the salaries, you know, through someone else. But some of them are literally employing community health workers directly. Some of them are paying community-based organizations who employ community health workers, and some are paying a rate for community health workers. Now, and I think that's still emerging, so there's still learnings on that, and I think that'll evolve. So I'll give an example. In South Carolina, they were doing some pilots where they were paying the community health workers, and they were paying a certain amount for, I think, a 30-minute face-to-face visit. But what they realized was a lot of that community health workers' time was really being spent not in the face-to-face context, but actually outside of that context doing the case management component of their job and finding the resources that the patient needed, for example. And so they were trying to rejigger and figure out what other codes they could use. They used some existing codes and just got a new provider designation is, I think, how they did it. So I think that is still evolving, but there are many, many examples. I think also different, you know, I'm using community health worker, I guess, just to say as a blanket statement. You know, it could be a patient navigator, it could be a case manager, you know, promotora. It's a blanket statement to kind of cover folks who are connecting patients to the services that they need, both in the clinical and the community setting.
Great, thank you. So we have a couple different questions that are related to licensure. So you made a comment early on that there could be advantages to being non-licensed, and so there were a couple of people who asked if that really advocates then for maintaining non-licensure across the field of breastfeeding. And then there was a different question that came in sort of asking an order of operations. If someone were to pursue licensure, in particular in this case for IBCLCs, would they want to do that before or after pursuing a state plan amendment?
Oh, those are such good questions. I'm not sure I'm qualified to answer, though, but I'll do my best. I'm not a workforce expert, but, you know, I mean, there's always pros and cons to regulation. Some of that has to do with your ideology, and some of it has to do with, I think, you know, just the hoops you have to jump through in an unregulated environment. You know, it might be more chaotic and there might be less standardization, but there's, I think in economic terms, they call it lower entry costs because you can enter the profession more easily. But in, you know, a more regulated or a licensed environment, of course, then you have to go through those hoops, whatever the licensure agency sets up. And I think the other thing is, you know, I've seen it because we've worked closely with the community health workers. There's been kind of a, you know, controversy over whether there should be kind of a federal standard for training and certification for community health workers, or whether that should happen in each state, or in some cases it's happening even more locally than the state. So I, you know, have heard both sides of that argument in listening sessions that have involved community health workers, where, you know, they want the profession to be one where you can move and still do the same work, and so a federal standard would allow for that and might allow for things to progress more quickly. Maybe not also. But then there's others who say, no, you know, there's different circumstances in different states, and each state should have the ability to define that themselves. And yes, the result of that is we probably have 50 different licensure systems that are all slightly different. So I think there's, you know, just depends, you know, personally on where you come from in terms of your own political ideology, but also there are probably pros and cons to both sides of the licensure argument. Now, the second question was one of timing, right, of whether if you were trying to go for a state plan amendment. That's a good question. I mean, I guess I think setting up a licensure system, I would imagine, involves state regulation. And state legislatures sometimes only meet, you know, 2 months out of the year. So it can take a long time to, you know, get a bill sponsored, introduce a bill, and get it passed in the legislature. So, like I said, the state plan amendment stuff isn't going too quickly either. So not to say that that's any faster, but I guess my gut is telling me I would want to approach the state, and if the state really felt uncomfortable with the profession, which is frankly where some states are with community health workers, because they don't tend to really understand, you know, how community health workers have a unique contribution in terms of their cultural competency. So states are a little nervous. What they see is they see them as uneducated and, you know, lightly trained providers in some cases, as compared to the providers that they're reimbursing now, you know, more physicians and nurse practitioners. And so I guess I would ask the state. I mean, I would think in the case of lactation consultants, to me, I think the state might have less nervousness, but maybe not, and it might depend on the state and, you know, the politics and the state and where the profession is in terms of its penetration in the state and how broadly accepted it is. But I would hope some states would feel comfortable that there are, you know, in place the right systems to assure quality. So that's all it is they just want to assure. If they're going to say we're going to pay for something and they're going to encourage providers to refer, they want to know that they're going to get a quality service. So that's all. They just want to have those mechanisms in place. And one thing TFAH has thought about is that the health department might be helpful in providing that assurance, because that's a lot of what the health department's role is, you know, even in going to inspect restaurants, right? So maybe that, you know, and also the health department would, I think, be a willing partner because they would know the evidence and want to achieve the same outcomes as with the lactation community. So I guess in sum, I would talk to the state first.
And that ties in really nicely with a question that's come in. I know you said it earlier, but again, precisely who within the state Medicaid department should a state coalition focus on contacting?
Oh, it's such a good question. You know, I'm not a public health person myself, so again, I'm probably not best qualified to answer that. But I'm thinking maternal and child health, just because again, like they'll, you know, the Association of Maternal and Child Health Programs has an issue brief on this. Clearly, they've been promoting with their members, you know, that this should happen. So I would think that that's already an educated community who knows the population and knows the need and knows that a gap exists that needs to be filled, and they probably have the same frustrations in terms of why does this gap exist, particularly for poor women. And so I would hope that they would be a good place to start.
Super, thank you. And then finally, you would ask for some feedback about people's experience approaching managed care organizations, and we've had a few people that shared that in their experience it's easier to approach, but in some states at least there's more than one. So it takes a lot of time because you have to go through that journey more than once within a single state. And then someone else shared that there is no Medicaid managed care plan within their state. So it's really going to be a different landscape wherever we're looking.
Exactly, and that's why I really would encourage people to go to the Kaiser Family Foundation website. It's like state-based facts or something like that it's called, and if you go on there, then you can find, you know, what is the managed care penetration in your state, and then this new chart that they have now will allow you to drill down and find out who those managed care organizations are. And I do understand the need to like go one by one is really a pain. That is a pain, but you know, being kind of competitive with each other, I think that, you know, if you say, well, so-and-so's doing it, hopefully that'll get the ball rolling.
Wonderful. Well, thank you so much, Anne, for your time, and again, for just breaking this down in a way that makes it accessible. And again, we are here affirming that all women deserve access to care and that all providers provide value in their care. There is a space for all of us and a space for all of this work to support moms and babies in our communities. And we look forward to continuing to work with Trust for America's Health and continuing to work with everyone on this call and beyond to move forward in a collaborative way. So thank you very much for joining us, Anne.
Well, thank you all. I really appreciate the opportunity, and I look forward to keeping abreast of the progress.
Wonderful. So I'm going to turn it over to Megan, who has some very important announcements about some of the new mechanisms for engaging with USBC. So please stay with us for these last few minutes. Megan?
Thanks, Amelia, and thank you again, Anne. This has been fabulous as an initial webinar on this topic. And yes, it's very apropos that you talked about staying abreast, since that is a phrase that we use often at USBC, pun intended. So in closing, I want to just update everyone on a couple of next steps, as well as other ways that you can connect and act and become involved in moving this work forward. And again, very thankful to Anne for all of the great examples and information that really helps to make sure that we are not reinventing the wheel, but of course, because we have 50 different states and territories and beyond, certainly there might be many different pathways that different states might pursue, both the blessing and the curse of being in our federal system. So you'll see on the next slide, one of the first things that we will be doing in the next couple of months is convening the first in what will become a series of quarterly state advocacy-focused networking calls. And because of the urgent interest in this particular topic and these particular opportunities or flexibilities, as Anne called them, the first one of these networking calls will focus on this topic, and we are looking forward to this as an opportunity for in-depth sharing and dialogue amongst the states, just as we've been able to begin on the national level about all of the different possible diverse pathways that could be pursued, are being pursued, have already been pursued in response to your unique environmental factors in your state. And we hope this conversation will help other states to plan a course of action that is most aligned with their landscape. A couple of logistics about these calls. The state coalitions, through our new communication mechanisms in our new website, are going to be asked to designate 1 to 2 reps to serve as advocacy-specific contacts. It's one of the coalition roles you might have heard us speaking about as a way to better target communication and ensure that we have a meaningful mechanism to have conversation with the appropriate folks. National partners, I know this sounds like something that might be very interesting to you all as well, and we certainly recognize that, and we want to continue to facilitate communication upwards and downwards and grassroots to treetops. But we want to make sure that this is also a time and a space for the states to really learn from each other and have their own space to convene and discuss. And so national partners, we really want to encourage you. This opportunity is really a significant one to make sure that you and your organization is liaising or has representative to the different states. USBC supports 50 state breastfeeding coalitions in all 50 states, as well as some territories and tribal organizations. So they are out there, and if your national organization has state chapters or state affiliates that are already in place, check to make sure, are they engaged with your state level breastfeeding coalition? Or if you don't have a formal structure, it might be something to think about having an individual person who is a delegate or a liaison to your state breastfeeding coalition. And likewise, the other way around, state coalitions, we know that we've been polling you and beginning to measure the degree to which the state breastfeeding coalitions have relationships across the spectrum of different types of organizations at the state level. Like the lactation support provider organizations, we also encourage you, if you don't have linkages to those different types of organizations, the lactation support providers that are in our field, to consider where do you possibly need to expand your network. So we are here to facilitate those connections in both directions and want to make sure that is really happening, because as Anne has said, it's very important that we all are working together in this conversation in order to maximize impact and influence on what is not an easy road toward some of these opportunities. A possible road now in ways that it wasn't before, but not necessarily easy. So we need each other. And then also stay tuned. We will be having additional webinars as the work under this program strategy progresses around the other 2 priority strategies that the Constellation has prioritized, as well as future webinars on our workplace side of this funding opportunity from CDC. So some ways to connect and act online. If you have not seen before, our new USBC website has an action directory with a specific web page to showcase activities on each of the Surgeon General's 20 actions. And any organization that is interested in loading their activities into that directory can do so. You can find more information at this link. You can also join learning communities, online communities where individuals can come together on specific breastfeeding topic areas, including these conversations we're having today. You can join these to share information and resources, learn from each other, and surface opportunities for collaborative action. And then also we have a story bank that we haven't promoted as much recently, but we are wanting to remind folks that this is here. Individuals can post their stories of different kinds of breastfeeding support here, and these stories are available to our member and partner organizations, state coalitions that might need to be telling individual stories, whether it's for things like hearings, advocacy campaigns, donation campaigns, all of those different types of work that we do to influence our society. Often storytelling is really powerful for that. So we encourage you to check that out and share stories as well. And of course, you can stay up to date. Many of you are probably already familiar with our weekly Wednesday Wire. You can also sign up on this link for our action alerts by email, as well as find us on Facebook or Twitter. So again, I want to thank Anne and Amelia as well for helping to moderate the question and answer session today, and all of you for joining this learning opportunity on a Friday afternoon. Thanks for indulging our strange time to host this session, but it has been great to have you. And with that, I will close out our call today. And again, immense thanks to all of you for being part of the alignment of the voice of breastfeeding advocacy from the grassroots all the way to the treetops. We are really looking forward to what we can continue to accomplish together to impact the landscape of breastfeeding support. So from all of us at USBC, have an enjoyable and hopefully beautiful spring weekend. Take care, everyone, and we will talk with you soon.